talked about earlier. First thing you're going to see is this, you know, this QR code. So if you would just go ahead and scan that thing, and it'll, like I said, it'll open up the Pull Everywhere app, and then it'll allow us to work through this going forward. So what I'm going to do is right off the bat, you'll get one first easy question so that we can all set the stage. You'll know how to use the product, and it'll help us, you know, work and function through going forward. So today we're going to talk about CPAP in general. You know, we're going to talk about capnography, and then we're going to talk about the system you guys are actually using today. Everybody scan that? Are we all good there?
Yes.
Beautiful. All right. So even if you didn't scan it, you can still access it by going to pulleverywhere.com or pullev.com, Ed Draper, or /Ed Draper 411. You can also text 22333. You can text Ed Draper 411 to that, and then it'll text back at you. You just input your ABCD or whatever, and it'll allow you to participate. So the first question is, CPAP forces air, it's a statement, right? CPAP forces air into the lungs to open the airways. Is that true, false, or is it an American Ninja Warrior holding up the spider wall, right? Spider walk. What do you think? This thing over here will tell me if I start getting some results. Let me know if you're having any issues with that working.
Stand by.
It might be the system too, so that's why I've got it pulled up over here in this other screen. I can make sure.
Is it? Oh. Is it showing results yet?
It is not. What'd you say, Don?
It took my response, okay.
Oh yeah, I see.
Yeah, a lot of us answered.
All right, let's see if it pulls up, because it's showing on my other system, but it's not showing here. So we'll see if it does it. It did. Excellent. Beautiful responses here. Let me tell you, gang. All of us were taught, most of us were taught, that CPAP does in fact force air into the lungs, when in fact it does not. And it's interesting, we'll go into this, and that's kind of the whole point at the beginning of this. What's interesting is that, there you go, someone changed their answer. So what's interesting is that I honestly believe that that was taught that way for two reasons. One, it's more simplistic. It was a way for us to understand it easily, because a lot of times people try to teach us to like a technician level versus a clinician level. They try to say, when you find this, you do this, and this is the result. This is how you treat it. And quite honestly, though it worked, because the end result is the same, it doesn't give us the true understanding of why we're doing what we're doing. And that's what I'm going to go through a little bit today. And I'm going to tell you C isn't wrong either. And we'll go into why that's not wrong here shortly. So lock in your answers there. Many of us were taught that it is, in fact, air forcing down the airway, popping open the airways and the alveoli in the bottom. And I'm going to tell you it's not. You know, many of us were also taught that it's a lot like putting your head out the window of a car. And it isn't wrong to think that, because it is. It's not, but it's not the air being forced in because we're driving, you know, fast down the road. It's in fact the fact that we're breathing against a pressure. And they taught us that because every CPAP on the market in early EMS use was designed around oxygen in flow, creating what we're breathing against to create that PEEP. And PEEP is, for those that may not know, peak end expiratory pressure. And what that means is just you're measuring how much pressure are we having to breathe against. And that's what that number comes out to be. What happened, and it was that this is a typical CPAP mask, and most of them are very similar to this. You know, they may be slightly different in how they secure and what the materials are, but basically it's a mask with a little hole in it. And like I said, in earlier models, it was air being blown through here, much like a non-rebreather mask. But because you have a restriction in the space for that air to come back out, it was difficult for us to breathe against it. And that's what creates the PEEP. That's why, you guys have been probably using this one for quite some time, but other models, you actually have to adjust the flow rate to create more PEEP. This one you don't, which we'll go into in a little bit. So I like to start with a little bit of basic anatomy, and I'm not gonna, you guys are smart, I'm not gonna make you go through and look through and talk about all of the basic structures. What I do wanna look at is this though. I do wanna look at down at the lower airways. You've got the arterioles and the venules that hook into the capillaries or become capillaries, and they surround the alveoli. And at that point, that is where, I don't know if you can see my pointer, I'll make sure you can. That is where the blood cells come through and gas is exchanged, right? I gotta make things easy for me, right? I need to make it a point where I can fully understand. I did this at an early point in my career, and it's stuck with me all along. Get ready for a lot of bus stuff. We talk buses a lot. So what I say is that those blood cells are a lot like buses, right? And the oxygen and carbon dioxide on those cells are like people on the bus, right? They take up space on that cell. And the cells that are full of oxygen are like people ready to go to work for the day, right? They're all coming on, they're refreshed, in most cases, full of coffee, ready to go out to work and get some work done. And so then those cells move their way onto the tissues, they offload the oxygen, it uses glucose and other things to do the function of that part of the tissue. And the byproduct of that is carbon dioxide. And that then, at the end of the workday, hops back on that bus and comes back to the alveoli so that it can exchange that gas and get rid of it. At that point, they're tired, they're beat, they're ready to go home. At that point, they exchange, and new workers get on the bus and come back into work, and life is ready to go. What I want to bring up here is that CO2 in the body is acidic, right? And if you have a lot of it in your system, you'll actually throw off your pH level, right? So it's necessary for us to get rid of that, and that's called, as we know, right, it's part of the respiratory buffer system. It's how we keep in balance. To take a little higher look at breathing in general, many of us were taught that you actually draw air in, like you forcefully, actively bring air in, and that's not true. And did you guys know that? Were you taught this proper way? Or am I alone?
Nobody here was taught that way, no.
No, you weren't? That's great. So I was taught that we actually forcefully bring it in. And so what I like to bring up here is that what happens is you have your intercostal muscles contract, the chest wall actually moves out, your diaphragm moves down. And as we all know, that if you have X number of air molecules in a space and we create additional pressure on that, or a smaller container on that, it increases the pressure. If you open it back up and make it bigger than what it was, then you're going to have a lower pressure. And then much like a cascade system, which you guys use to fill your air bottles, the atmospheric pressure in this case, or in our case, would be higher than the pressure inside the lungs when the space is larger. So that draws the air in, and then the muscles relax and the diaphragm goes up, and that's what pushes the air back out. It's because of pressure gradient. Is that how you were taught? I'm excited if you were, because I sure as heck wasn't taught that way.
Yeah.
No, they were all taught the way you were.
Oh, good. Well, that makes sense. So that's why I like to cover it, because many of us were taught, the wrong way. And honestly, I believe a lot of that is because they don't give us the credit we deserve for how smart we actually are, right? They're trying to, and I get some of it's cramming lots of information into a short period of time for us to get through the paramedic program. So when you start talking about lung sounds, this is another thing I found often early, is that we're taught that in order to listen to lungs, you're going to compare side to side, right? And you're going to work your way down. But what I like to point out is that those lungs don't go all the way down the rib cage. In fact, they stop at basically the base of the xiphoid process, and they go just a couple inches below the tip of the scapula. And early on in my career, and then many times while I was precepting newer, providers while working, I'd often have them listen, and they'd be listening down towards like the kidneys and the liver and stomach sounds and things like this when they're trying to listen to lower lobes. And why that makes a difference is, if you're not going to hear breath sounds there. So people will often think I have diminished basses, but you don't. You probably just don't have liver sounds, which we would expect. So I like to make sure we point that out, and it allows you to help new people coming in to make sure that they think about anatomy when they do this. When you start talking about, any questions before I move into the next part? This is kind of a stepping point.
No questions over here.
Awesome. So listen, I'm not going to go deep into pathophysiology of the different diseases that we're going to treat, because you guys know it, right? We're all continuing our education in this point. We're not taking initial education. So one of the things I like to look at is I have to assimilate everything, right? So when you look at the airways and you want to associate what's actually physically happening with the airway conditions that we could be dealing with, the reactive airway disease, what kind of illnesses fall under reactive or restrictive airway disease? What would you guys say?
Asthma. Anything else, guys?
Yeah, asthma or allergens, right? Things like,
COPD.
yeah, COPD can have restrictive airway, reactive airway. Great, good. So what I like to say is that's like, if you're transporting air back and forth out of the air into your lungs, let's just say it's another bus, right? You're moving that stuff in. And a reactive airway disease is a lot like having a narrowed roadway or a congested roadway, just like you're seeing here, right? And a wide open roadway makes it easy to move that stuff back in and out. In a reactive airway, there's, the swelling and there's constriction of the smooth muscles and things holding that down. And there's going to be a reason why I'm talking about this here in just a few minutes. You'll see, but ultimately, you can't move air well because the actual structures aren't allowing you to move things very well, and it's just because things are clogged up. COPD, on the other end, is more like restricted because the roadways are narrowed in chronic bronchitis, right? But also the roads are beat up, right? And in the COPD world, emphysema world, that's a breakdown of the alveoli, right? And if those are broken down or damaged, then they're not going to move the gas back and forth well across the membrane or back and forth through the bronchus, right? When you start talking CHF, you can move that stuff, right? The buses can move through water, but they don't do it great, and they kind of have to push their way through, right? That same thing happens as you're trying to transfer gas through liquid in the alveoli. It works, it has to fizzle through the water a little bit. It might take a few seconds longer, or milliseconds longer. So I want to make sure we kind of assimilate those things, and I'll show you why that all makes sense in just a second. Let's talk about how CPAP, well, before I guess we talk about how CPAP actually works, do you have any questions on what I was talking about with those three things? Does that make sense?
Yes, makes sense.
Awesome. So CPAP in general, the way it actually works, the body does it inherently, right? So we've got the two things we were all taught when we're trying to differentiate COPD versus CHF, right? And there was the pink what and the blue what. Do you guys remember?
Pink puffer,
Pink puffer,
blue bloater.
Blue bloater. Yep. And the idea behind that is it associates with the signs and symptoms or the presentation we're going to see with those people. So in this case, what is our friend there doing? What would you say she's doing there?
Pursed lips.
Yeah, she's pursing her lips, and her skin doesn't look bad, right? So why do you think she's doing that? What do you guys think?
She's creating PEEP.
Yeah, naturally, right? So the human body is a wonderful thing, right? We can actually create natural PEEP, and people do it. So when you walk into that patient and she's working to breathe and she's pursing her lips and she might be tripoded out and she's doing this, she's trying to open up her airways to allow a couple things. First and foremost, one that I never thought of, but as the exchange happens at the alveolar level, if the gas can't get out because the airways are restricted, it actually traps CO2 in there, right? And if it can't get out, it feels like she can't breathe, right? Because she's not able to bring in the oxygen like she needs to. So that PEEP creates a stenting of that airway and holds that open so that the air can release. So additionally, that PEEP that she's creating on her own takes energy, right? And she's already working to breathe. She's already not in a great position. So it takes a lot of work. So us applying CPAP to her early allows her to use less energy to do the same thing, right? And what's neat about your system, this is the system you guys use, and I'll give you a little bit on how it works. Air and oxygen come in from down here. This part right here is an anti-asphyxia valve. And when air is pushed through, air and oxygen are pushed through, it flips open that anti-asphyxia valve because they're breathing from here. It goes in through that same little hole we talked about before, and it's flowing at a really high flow rate. So we'll go through more of that in a minute. But when they breathe that in, they exhale, they breathe against that, and then they're breathing against this exhalation valve. And this is what differentiates your CPAP from every other CPAP on the market. All the other CPAPs just have an exhaust port, and they're relying on this pressure and flow rate to create what that person's breathing against. This unit requires this exhalation valve, and there's a spring inside this that you create additional tension on. And what's neat is you'll notice your system, unlike most other systems, does not require a manometer, which is obviously it's going to measure that pressure, because it doesn't need to. Each one of these units, every single one of them that comes off a line, they test this thing to make sure that the spring tension is exactly what it needs to be at each of those steps of the process, so that we know we're giving the right amount of PEEP. So really cool. One less thing for us to have to focus on when we're trying to deal with everything else and determine what meds we're going to give and what other treatments we're going to do and what, if we're getting lines going and all those kind of things. So you'll also see there's an inline integrated neb into this system, which is pretty cool. No more T pieces, anything like that. So what happens with that PEEP physically is here's a cutout of the airway. A standard airway, you'll see some of the air just kind of moves around in here, and they have to physically open that and move their tongue out of the way in order to breathe. Well, with CPAP, it actually stents open the airways so that the tongue's pushed back a little bit, the upper airways are moved up, and it actually elongates your trachea and opens that up as well. So you're stenting that area to allow free flow to go back and forth. And here's where that American Ninja Warrior comes in. She also hops in there and holds open the bronchioles too, allowing the trapped gases to come out and then new air to come in. And then in the end, and this is again where most of us were shown that the air forcing down pops this up. It really doesn't. The back pressure then that we're creating recruits more alveola by popping them open. And in bus fashion here, it creates more bus stations for us to move that gas back and forth. Makes it a whole lot more efficient, right? So does this make more sense?
Yes.
Beautiful. Funny thing it also does, and again, learned this relatively recently. If you guys haven't seen it, you should definitely look up FOAMFRAT, FOAMFRAT. There's a guy named Tyler Christofoli and a guy named Sam Ireland, and they speak about many different topics. And they were doing a talk on CPAP and brought up some of the coolest things I've ever seen. So I didn't know that that it actually affects you. I guess I knew it affected your cardiac output, but I didn't know how it affected the cardiac output. And what happens here, as that pressure comes in, or I guess I should say pressure is being created by you breathing against the resistance, you increase the pressure on the pleura, which opens up more lung tissue, recruitment of more lung tissue. And it'll actually put pressure on the superior and the inferior vena cava. And what that does is it actually reduces your preload to the heart. So in a CHF situation, it reduces what's getting back to the heart, allowing the heart to beat more fully, and it allows it to catch up. And it'll increase the afterload because of that stretch it's allowing it to do. And this is on the right ventricle. It then pushes that off to the lungs, does what it's supposed to do there. But by putting that pressure again, you're decreasing the preload and the afterload on that left ventricle, which puts less tension on that right or that left ventricle, allowing it to beat more efficiently and moving some of that fluid around, which is super helpful. And like I said, that's happening because you're splinting that airway out, and you're pulling traction down on the airway and increasing the pressure within there to recruit more lung tissue. So it's definitely a good thing to do, and it's a good thing to do early. Many of us will try to hold off on doing CPAP until the patient truly is sick. We're like, oh, are they really, really sick? Then I'll put them on CPAP. If they're not, maybe I'll just try an albuterol treatment or something. But in fact, the sooner you get them on CPAP, the faster they're going to turn around because of this this process we just went through, that lung recruitment. The sooner you get it going, the faster they're going to turn around. Does that make sense?
Yep.
Yeah, makes sense.
Awesome. So capnography, I like to go into a little bit on what we're going to talk about here for understanding why we're going to look at it more than what we do today. Currently, my understanding is you guys, and you're not alone, because there's a number of people in the state that do this, primarily use capnography for cardiac arrest. Would you guys agree your crew's that way? I know every shift's different, right? So would you say your shift's the same way?
Yes, definitely.
Yes.
Yeah, it happens, right? It's what we were all taught. There's another big thing you can use capnography for, and what is that? That you guys are probably starting to do it for, and it's pretty, it's pretty new. What would you say you're using capnography for? Has to do with cardiac arrest, though.
EP tube placement.
Yeah, she was right. Yeah, so ET2 placement's what we always used it for, but absolutely ROSC, right? So we're able to use it for ROSC. And what are we looking for? How do we know we get ROSC through untitled CO2?
When it jumps up to 35 to 45.
Yeah, you see a big spike, right? Yep, that's exactly it. So any cardiology geeks in the group? I know I'm one. So anybody else with me who's wearing the cardiology geek hat? Anybody in the room?
I don't think we have any in the room today. Maybe
No?
one. Maybe one.
Maybe one? All right, well, maybe that one,
Yeah.
we'll see you here. So I'm sure many of you, anybody that, like myself, been doing this more than a couple of years, have said, man, you've had that patient. You walk in the door, you see them, they're like this guy here, they're sweating like crazy. They're doing Levine signs saying, my chest feels like there's an elephant on it, blah, 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 the same, same old. You probably could say, and I'm sure you have said, I know I have, I didn't need an EKG to tell that guy was having a heart attack. I could see it across the room, right? And that's great. It's true, right? There are cases out there that are so sick that you can tell across the room. There's COPD or CHFers. I could hear the gurgles from the front door, right? We've all said those things too. But what did 12 lead do for us that, when they first came out, we started using them more often? What did it do for us differently than being able to see that guy across the room? What would you guys say?
To identify the part of the heart that's affected.
Yeah, it absolutely allows us to see more certainly what part of that heart is being affected, right? So with that, let's see that quasi EKG geek in the room. What do you see on this this EKG? What do you see here? What's obvious? I'm not looking for, Tim Phelan answer with all the,
Inferior wall.
yeah, inferior wall, right? Which tells us what? What part of the heart's having a problem? The bottom, the right? Those are good chances. That's probably a right coronary artery. We have some reciprocal changes here, so we know that it's the real deal, right? But what I want you to also see is this, and I hope you see, is that this also has a left lower lateral, right? This would be upper lateral, but this is a lower lateral involvement, which could be a bivessel disease, right? It could be two different clots or two different narrowings that are exacerbated, but let's say it's not here. So you've got the bottom, the right, the lower left, and there's one more indicator here. Where's that EKG guy? What other part of the heart is injured here? The posterior
Is it
wall.
the posterior?
Yeah, absolutely. The posterior wall. You see the depression here? This is where you'd look at the backside of the heart to see if you've got elevation there. If you do, what's significant about that posterior wall? Anybody but Abby, because she's heard this. What do you guys think? What does that posterior wall do? It feeds. Go ahead.
Oh, sorry. It feeds the AV node. We got an answer in here.
Yeah, it does. The posterior wall feeds the AV node. So when you look at this EKG, before it was, I can see across the room, this guy's having an MI, right? But what does this EKG tell me? It gives me a better picture, right? It not only tells me that a ginormous part of the heart is affected, but it also tells me I should anticipate what? If that AV node is not being fed properly, what should I be anticipatory for?
Change of rhythm.
Yeah, rhythm changes. I'll tell you, this is the one, if I see this guy, this is one I'm actually putting defibrillator pads on the way to the hospital, right? So what I'm trying to get at here is this. We went from a 3-lead EKG and the fact that we could, use our signs and symptoms, and often we would find these things, right, with obvious signs and symptoms, but we now know deeper why we're doing what we're doing. And quite honestly, you guys can agree with this, I'm sure. You've had patients where they didn't show outward signs and symptoms, but the EKG showed you they were having a heart attack. Have you guys had that? You may not had that. It's probably a better question.
Yes, we've had that.
Right, everyone has, right? So I'm going to tell you that capnography is the same way. You could put capnography on a patient, and today you're using capnography more for, like we talked about earlier, the capnometry, the number end of it. You're using it for tube placement confirmation and looking for ROSC. And that all can be told by the number. But what I'm going to show you here is that you can actually find more through doing an actual capnograph. And so like I said, capnography, the graph is the actual depiction of what you see. Capnometry is the number that pops up there. And interestingly enough, gang, until I came to work here, I didn't know this. And I'd love to hear if you do, but you've got these on your truck. You just don't use a ton of them, you said, or at least that's what the last 2 crews have said. What's interesting here is when you go back out to the trucks today, I'd love to see that you want to pop one of these things open and take a look at it. You're going to see right along the ridge here, there's going to be some holes on both sides. And you can kind of see them here. See this ridge? There's some holes right there. That's actually where the oxygen's being delivered through. It's not being delivered through the prongs like a normal nasal cannula, like we would assume. The prongs and this cup are sampling the CO2 levels and drawing it back through this tube into the monitor to have it monitored or displayed what you're supposed to get there. The other one obviously is oxygen, and that's where it comes through there. So it doesn't matter then if the patient's breathing through their nose or their mouth. And that's why, that's one of the many reasons why it's important to make sure you're using, the proper brand of the product that works with that monitor. What I always say is this, like we talked about earlier, CO2 is like the off, the off gas of our cellular respiration, right? So it's a lot like the exhaust from a powerhouse, right? And that's why this picture's down here. So just like you said earlier, when all of a sudden those things start to work and we're moving things that weren't moving for a minute in cardiac arrest, all of a sudden you're going to see this big billow of CO2 in a cardiac arrest situation. So that's why when these things are held back and all of a sudden it pops out, there's that number. What we're going to look at next is what that graph actually does, right? So that number, this is an exaggerated version of what you're going to see on your cardiac monitor. So your number is along the side here, and it's depicted by the height, and your timeline runs this direction. And that the number of waveforms you see within that period of time, the more there are, the faster they're breathing, the less there are, the slower they're breathing. And then the waveform that depicted, it's kind of interesting. I was shown, when I first saw this, I had to look at it a few times because it seems almost backwards to me, at least. This is actually the downward deflection towards A here, or the DE phase of the capnograph is actually your inhalation. And then your exhalation is what we're actually looking at here, which makes sense when you're looking at CO2. So your BC part of this phase is the first depictor of how you can actually see what you're potentially looking at for conditions through this phase. And then you'll see that it kind of plateaus and still generally rises a little bit till it hits this D point. And that is where the actual value is evaluated for your end tidal CO2. So if we're going to look at a reactive or restrictive airway disease, then what happens here, and this is where we go back to the buses I talked about earlier, what you'll see is in some cases, or most cases, you'll start to see this shark fin looking morphology. And the reason you're seeing that is the fact that, the respiration goes in, or inspiration goes in, and then as it's trying to get out, this tissue over here is not allowing, because it's restricted, not allowing that flow to come out as quickly as you would like it, or it would like to come out. So it's delaying that over time. So that's why you start to see this shark fin. And often they're retaining CO2. So you're going to see this number is actually elevated, right? You'll see that this is the approximate normal, and then you'll see those are going up. Does that make sense? Any questions?
Yes.
This spot usually brings up a question or three. So I just want to make sure you don't have anything here.
No questions over here.
Awesome. Good. All right. So now let's look at a edemic airway, right? So if they've got edema in there, what you're going to notice, just like I talked about earlier, was that bus is flowing through water, it can still get there. It just takes a little bit of extra time, and it's not as crisp, right? So what you're going to find is here's your normal, and this is extremely exaggerated, right? This would be a ton of respiration. So what I want to show you is that what you're going to notice, the big indicators are that the number, the capnometry, could be normal. This one's around a little end of low, or low end of normal, but it's normal. And then you're going to see the CD, or the BC, right? The C and the D sections of those are more rounded than crisp corners, like you see in a normal. So when you see rounding of those, that's telling you there's probable fluid in the lungs, or CHF of some sort. It's working on one side or the other of the alveolar wall. Does that make sense?
Yes.
Awesome. So now the third part, and then there's so many more you can see, but I'm only really going to hit these three main categories. So we're looking at shark fins, we're looking at rounded transitions at C and D, and the last one that I really want you guys to see is the perfusion end. So not only can you tell that there's perfusion up front, like we're talking about with cardiac arrest, and you see that big spike for ROSC, but you can see it falling off too. And likely you're going to see this falling off before you notice blood pressures drop, right? So that, who knows, right? Your monitor could have been wrong. It could have, it could have missed a cycle. Something could have happened, right? So this is going to be consistent. And you're going to see it. So one, it's likely going to be low, but two, you might start to see some of this rounding. But what I really want you to notice is the rounding, it could be there, but you're also going to see progressively lowering CO2 levels. And that's telling you that person's circling the drain. We got to do something now because they're not doing well. So not only can you see if the person is dealing with, a bronchospastic airway, or if they're dealing with edema, but you can also see if their perfusion is falling off over time, right? Again, this is super exaggerated. It'll never be, it shouldn't be that fast. If it is, we're pretty much out of luck, right? We're not going to do any good for them. Does that make sense?
Yep.
Awesome. All right, let's pull out the game again. So same thing, right? If it's either on your phone already, or you can go to this website, the pullab.com /EdDraper411, or text to or EdDraper411 411 to 22333, and then select from there. It looks like I don't see any responses over here yet, but much like an ECG, a capnograph will show you either A, conditions that may not be outwardly present with other signs and symptoms, or B, only conditions that you can also see other signs and symptoms. Doesn't look like today it's actually letting me know when you're doing this. So if you are putting things in, let me know.
I believe we all answered over here.
Beautiful.
All done.
Beautiful. All right, let's pop forward and see where you're at. Love it. 100%. That's what I'm looking for, right? So big thing I want you to see is just like that EKG, right? You don't always necessarily see the condition, right? And the same thing can happen with a capnograph. You can start to see bronchospastic airways before you start hearing, major wheezes, right? We've all spent too many years in an ambulance, right? Or a fire truck. Too many cue sirens ruin your ears, ruin your hearing. So quite honestly, this is probably more accurate than what we believe our hearing is, right? So that's good. That's a great one. We'll lock those answers in, and then we're going to go look at your protocol, right? So this is the state model protocol, and my understanding is Macomb County really hasn't changed much from the state model protocol. But here's the flow chart that goes along with it. And trust me, I'm not going to make you go through each little spot and read each of the sections, but we're just going to kind of go over a high level of everything. So first and foremost, we're having someone with respiratory distress, we're going to listen to breath sounds, right? And if they're clear, in EMS, we always look for the worst case scenario and try to work back towards the lesser case scenario, right? Because we want to treat what's going to kill them first versus, what may be able to be treated in long term. Clear lung sounds, one of the biggest things we're going to look for is blood clot, right? Are they dealing with a PE? Are they just having an MI, a heart attack, causing, some type of respiratory secondary cause or problem? And basically, you want to know, are we dealing with drama or trauma, right? Is it a real, I shouldn't say real, is it a physical condition that we can manage, or is it a emotional condition that we can manage a different direction, right? And so that we're going to head that direction with that. So when you start talking asymmetric breath sounds, then we're going to be worried about obviously tension pneumo or hemopneumothorax, and we're going to be worried about decompressing that chest at some point. Interestingly enough, when you start talking about stridorous airways, obviously the first thing we think about is an obstructed airway, right? But what we want to know is, where is that obstruction at? And the thought behind that is, if you only hear inspiratory stridor, when they're bringing air in, that's when you hear the noise, then that's likely supraglottic. And why do we care about that, Abby? Why would that be significant for us as ALS providers?
Can you repeat the question one more time?
Yeah, no worries. So, you know, if we only heard inspiratory stridorous noise on a possible airway obstruction, and that would lead us to believe that obstruction is supraglottic, right above the glottic opening. Why would that be important for us? Well, as an ALS provider?
So you're saying there might be something in the airway that we can get out with like the forceps?
Yeah, you guys could go in with, you know, a set of McGill's potentially, right? If it made sense for the patient and get those things out. If it's biphasic stridor though, right? If it's both inspiratory and expiratory, it could be at the glottis itself, you know, like epiglottitis or something, but it's probably down below there. And why do we care about that? Because if it gets to the point where I have to crike that person, I need to worry if I'm going to have a piece of steak in my incision, you know, and I need to know what I'm looking for. And that's going to kind of help you understand that, right? If you're starting to talk only expiratory stridor, then it's likely down below the cervical region of the trachea, right? So it's down towards the carina and below. And in some cases that might be all right, because obviously emergently they're still moving air and will be okay for a minute. We're obviously going to monitor that person for changes, but it might be something as simple as them going in to do a bronchoscope and pulling out whatever pieces are in there. So what noises you hear are really important to mentally note and obviously document in the future. And then obviously that could be associated with allergic reactions and other things like that. So if there's not a foreign body airway, we're going to consider those type of conditions as well. When you start talking rhonchi, you know, rhonchi is more like there's secretions or some type of fluid within the bronchus, right? And when you start talking wheezes, that's more like narrowing airway from COPD and asthma. And I guess that, you know, you could get some of that from obstructions as well, but we're gonna lean more towards that for now. And then when you start hearing rails or crackles, that's the whole snap, crackle, pop serial thing that you hear with, you know, with a fluid or edemic airway, right? So the nice thing to know, the good thing to know is that all of those, except for maybe the stridorous airway, right? Those can all be treated with CPAP. All of them, right? If we go further down that protocol for you guys, obviously the first and foremost thing we want to do is throw them on a capnograph, right? We want to be able to look at not only the number for the capnometry, we want to be able to look at the graph to see where they are, how bad are they now, and then you can evaluate what did I do for them and did it actually help, right? So the second thing, and this is why if you buy the kit from us, we sell it to you with the capnography in the kit. If you do the hospital restock thing, you don't always get that, but make sure you're using that underneath the mask of the CPAP. You'd be surprised how many people try to put the filter line, the one that goes on the tube in line on your CPAP. It's really not what it's designed for. You want to have that Untitled CO2 as close to the carina as you can get without shoving it down their throat, right? So basically you want it at the nose or as close as you can on a tube so that you get the best reading you can possible. So then you can put your CPAP on, and obviously the next thing we're going to do is look at bronchodilators, right? So what I'd love you to do, and I try to challenge people with this all the time. I used to do it as a EMS administrator in the past. Whenever I saw someone use an Atrovent, I always kind of charge them with, tell me why you're using it. And I'm not going to go too deep into my thought process on that, but ultimately, I'd love you to look up the mechanism of action and how it actually works and what type of class the drug falls into. If you look, it's actually an anticholinergic, and if you have an asthmatic geek in the room, sludge symptoms, right? Those are one of the things that we want to look for. So though there is long-term, bronchodilation factors, and it does work for what we're looking to do. That's why the standard practice is to give ANA, or DuoNeb, or whatever term you guys are using. Just what I always challenge people is to be better clinicians. We should be able to discuss why we're doing every step of what we're doing, not just, and the answer should never be, we just do it because that's what we do, right? I gave this medicine to this person for this reason, And that's why. Because ultimately, guys, what I want you to think about is every time we give someone a medication, you know, especially if they're, you know, they're brittle and they end up having to use the system or their medicines and the rescue inhalers often, the more often you give somebody a medication, they can build up a tolerance. And honestly, if you think about them personally, eventually they might become, you know, tolerant to those medicines and have to go on something more expensive like a Zopanex or something, right? And we don't want them to do that. We don't carry that. Long-term, make sure you're treating the patient, you know, based on your clinical judgment, not just a protocol. What's neat, gang, this is something that I didn't do until basically I noticed in the protocol change a few, you know, whatever that was, 5 years ago probably, that the post-medical control contact is here. They are allowing, and they honestly, they're good after you've given the nebulizer treatment. They would like you to do some type of a steroid, right? Sooner you get that on board, we may not see the effects pre-hospitally. We likely won't see the effects pre-hospitally, but for the patient's benefit, they're going to be better off longer term by having that. What's neat, I don't think we have this. I'm sure it must be there now, but you know, what's neat is that your protocol allows you to choose, and it sounds like your box you carry in your box both oral prednisone as well as, you know, your IV solumedrol. What determines for you guys how to differentiate between which one you're going to use? What would you say?
I think whether or not they're able to swallow.
Yep, that's it. That's exactly it. So that's cool that you guys have that option. That's pretty interesting. Like I said, it looks like the whole state can, but I believe that when I was working, we only had solumedrol, so that's great. So then, what I like to point out here, gang, again, pre-radio, if that person cannot tolerate nebulizers for whatever reason, we can give them some IM epi pre-radio. So don't wait, right? You don't have to. If you're clinically down, if you're following the right pathway, you're determining this person has a bronchospastic airway, your capnograph agrees with you, there's really enough stuff in what I call the basket theory. You got enough stuff in your basket to say, yeah, this is the running diagnosis I'm going with, and you're able to do that. Now, post-medical control authority, then you can do obviously a second thing epi and start talking mag sulfate. Why do you think, why mag sulfate? And obviously that goes in a bag. You put 2 grams in a bag and run it over 10 minutes. But why? Why are we doing that? What's the reason? And this is what this kind of questioning that we should be doing to each other on a regular basis is how we increase our ability as a clinician, right? So what do you guys think?
Nobody seems to know.
I love that, right? Because I'm telling you guys, you're not alone. This is not abnormal in our industry. And I'm excited to hear you say that and be able to admit it. It's because there's smooth muscle relaxant properties to it, right? And you have smooth muscles in your bronchus. So guys, I'm telling you, and there's probably other reasons too, but that's the main reason, right? So I'm telling you, this is what we should do to each other, is look through these things and say, well, geez, why would I do that? Right? And that's how we improve our, you know, our clinical abilities and honestly, the profession as a whole. It's good, guys. So that's why I wanted to do this. But literally, it's the reason it's in here. It's not abnormal. It's actually super common for us not to understand why we're doing each step of those things, other than, again, that technician level. They crammed it in our head at in paramedic school. You do this because you find this, and that's why, right? And hopefully it gets better. Cool. Let's pop back into one of these pull everywhere things. So again, pullev.com/draper411, or you can text that Draper411 to 22333 and throw your answer in there. If for some reason it's not telling me when you guys are responding, so let me know when you've thrown in your answers, and oh, there's one. And then we'll do a little research, see where we're at. So CPAP can be used for which conditions? Congestive heart failure, an exacerbation of asthma, or an exacerbation of COPD, or all the above.
I hope in the future you write all my tests.
You know what I got here, Don? You'll love this. And shout out to Doug Smith if anybody's taking his class. This is was a requirement for him. You got to have these things, the longest one in one side, and it has to work its way down to the other. Whether he went shortest to longest or longest to shortest, it's just apparently an aesthetic thing that he was big on. So shout out to Doug. I love that guy. All right, cool. Let's move forward, see where we're at. Beautiful. All of the above. That's exactly it. And, you know, obviously it's the asthma is a change thing, right? For the longest time, we weren't allowed to use it there. And so they find a lot of clinical benefit to that. Lock those answers in. And now, shark fin morphology is suggestive of pulmonary edema, pulmonary embolism, respiratory decompensation, or restrictive and reactive airway disease. This one's sometimes.
By the way, you're not going to be getting quite as many responses from us because the majority of the room left and went on a call.
No worries. I get it. I remember those days. I don't miss some of that. Can't even finish a meal, right? In some cases. So this one's been giving me a fit. If you did put answers in, just let me know, and then we'll see if it pops up. For some reason, this one doesn't seem to want to do what it's supposed to do. Someone just throw it out there. Throw out their answer orally. What would you call it?
Well, we have some that say C, some that say D.
Beautiful. I love it. So that's great news. So the shark fin, sure, I could say that I would agree that it could be an early step of decompensation, but I wouldn't say that it's suggestive of that in and of itself. It's definitely restrictive and reactive airway disease. So when you see that shark fin morphology, then you can assume that they likely have bronchoconstriction going on and that they're going to need some type of bronchodilator. Yep, that's good. Cool. So rounded transitions at C and D on a capnograph could suggest either A, pulmonary edema, B, pulmonary embolism, C, respiratory decompensation, or D, reactive airway disease. Looks like you're getting some answers. Who? No. So I will agree with B, right? B would be a good one. Pulmonary, I'm sorry, I just lied to you. I would agree with A as pulmonary edema, and that is exactly where we want to go. I'm sorry, I looked at that wrong. Pulmonary embolism probably isn't going to show up there because it's happening on the other side of the lungs, right? It's not happening in the airway, it's happening in the vessels in most cases. And you could also have answered C, respiratory decompensation. Why would you guys think that would be? But there's one big differentiator on decompensation. What would that differentiator be? You'd start seeing a lowering of the capnometry as well, progressively. But yes, pulmonary edema is the right answer. Let's see. Cool. So ultimately, guys, we want to look at is what I'm doing today actually helping the person, right? In the COPD world, I want to look at my end-tidal CO2, the number, capnometry before. I want to see that it's actually decreasing. It's likely they're going to be, elevated. I want to look at their obviously look at their respiratory effort, respiratory rate, work of breathing before and after the treatment. I'm going to look at breath sounds before and after the treatment. I'm going to look at an actual capnograph before and after my treatment. And like I said, and hopefully you're going to see a reduction in shark fin and more normalizing plateaus like this. You're going to look at SpO2, you're going to look at heart rate, things like that to see if what you're doing is actually working. You're going to find a lot of the same things in CHF. The difference is it may or may not normalize because it may have already been normal for a capnometry. You're going to look for those same work of breathing, effort, respiratory rate, sounds, and before and after. But on the capnograph, I'm going to look for rounded plateaus, moving to more of a normalized plateau, and hopefully, normal respiratory rate and SpO2. So now, just want to make sure you guys are still hooked up here. Any questions, I guess, before I go to your actual kit? Don, are you still able to hear me, or am I broken?
Oh, I got you.
No questions.
No, I don't think we have any questions.
Beautiful. All right, just wanted to make sure I wasn't lost there for a second. Cool. Let's talk about your actual kit, guys. This is the meat and potatoes here. So we talked about capnography in general, or I'm sorry, we talked about CPAP in general. We talked about how capnography plays a role in this. Now we're going to look at your actual unit, and even after this training has occurred, there's some changes you guys are going to do in your regular practice because of this, already based on what we've talked about. So I want to make sure you guys are caught up with those things as well. So first and foremost, I want to see you guys using capnography, every time you've got somebody with respiratory distress, obviously, but also consider using it for pain management, right? You can monitor your actual respiratory rate with that thing. Consider using it with anybody that could potentially be shocky, right? Because we want to be watching or monitoring for any potential reduction in that capnometry and those waveforms that would be associated with, decompensation. So you're going to put these things on first. The kit we sell comes with that right in it. The next thing is you guys have one of two things right now. We're going to fix this. Right now, you guys are primarily using the little green spinny thing that goes on the disc port, right? So you're going to hook that up on that, and I'll show you that on the next slide a little bit deeper. But we also, when we sell it to you, we make sure it has this this OMETA connection right on there. And this OMETA connection will hook into a connection on your portal that I'll show you in a second, but it'll also hook into the wall of your ambulance and into the wall of the hospital, and you can walk right away. So now this is important. You're going to see this on your next form of questions, but this draws 15 liters a minute off your tank, off your oxygen source. And then through this filter right here, it entrains another 125 liters a minute. So 15 and 125 delivers about 140 liters a minute, approximately, to the patient. Obviously, there's friction loss and such, but the next thing I want to point out is on your system, it uses an actual vent tube. And what's interesting here is there's many different units out there that just use a standard oxygen supply. And what I want to challenge you guys with is this: if hospitals knew that they could get away with using an oxygen supply tubing to do this, they probably would, because they're significantly cheaper, right? So to show that you ultimately need that extra space to deliver proper flow to the patient so they can actually breathe on this device without over breathing it. And I'll go into that in a second too. So they have an actual vent tube that goes up to your unit. Then that's where, like I said earlier, the oxygen air come in, anti-asphyxia valve closes, goes into the patient be able to breathe. It comes as an exhalation, or it goes through this exhalation valve here. And what I want to show you guys is this. Make sure you're paying attention right here. So this is your exhalation valve and PEEP, right? What I want you to see though is that for this picture, they turned it sideways so you can see that there's three different numbers, right? You've got 5 of PEEP, 7.5 PEEP, and 10. But the exhalation ports are actually on this side and that side. And if it's twisted to this side, you're actually blowing air into the patient's eyes every time they exhale. So it's best for two reasons. One, to not do that by having it point forward, but also when you're sitting in the bench seat or even in the CPR seat, you can look at the patient and see the numbers that you have it set on the front, right? So make sure that those are moved forward. The neat thing is then it goes from here. Obviously you've got an inline integrated neb, and because you're using a disc port on your portable, this allows your the nipple or the Christmas tree to be available for you to nebulize right at the patient's bedside. And there's a key reason why I want you to do that. And the key reason is this: there's data to prove that even if a patient isn't truly like dire right this minute, the sooner you get them on CPAP, if they then become sick enough to have to go on a ventilator, the longer time you have them on pressure, right? The longer time they're actually breathing against that pressure to create PEEP, the shorter time that they're on the ventilator and the sooner they can get out of the hospital. So many of us think, well, gosh, I'm just going to, only use the CPAP if they're really, really sick. But there's a lot of data to show that if you get them on CPAP sooner, then they're going to do better in the long run. It may not change what you and I see in the ambulance, but it's going to change that person's life, right? So make sure you bring that into the consideration when you're putting those things on. If they're right on the cusp of, yeah, I might or I might not, you're better off to say, I'm just going to. It's the right thing to do. There's less damage that can be done by putting them on it than there is by not. Does that make sense?
Yes.
Beautiful. All right, so here's another look at your system. So what you're going to do, and this is one of the changes that are probably going to happen. I'm talking with Josh, and we're working on getting this adapter put on every one of your portables, because what I don't want to see you guys doing is having to, fiddle with this screw at 3 a.m. where you forgot your glasses and the person's trying to breathe and you're trying to work this thing on. What I want to make sure you're doing is you're able to just snap that right in like you would your regulator to the wall of the ambulance. The second part of that, what that does, guys, is there's pre and post regulator flow. So if you look at a regulator, and this is the same as your wall regulator, the disc port here is pre-regulator. And what that means is it's going to pull 50 PSI off your tank, which means it'll drain exactly at 50 PSI consistently till that tank is empty. On the post-regulated side, that might change as pressure changes in the tank. So you might see that lower down, and you'll need to adjust your flow to make sure you're where you need to be, right? So you should always be hooked pre-regulator. And what that means is, and I know you guys are doing it, many people are, and this is one of the things I'm trying to challenge people to change, is let's say this is what your port looks like in your ambulance hanging off the bottom of your regulator, and you have a Christmas tree there. Many people are pulling that Christmas tree off and screwing this thing to the post-regulated side of that system. You shouldn't be doing that, because it then doesn't give you that consistent 50 PSI, even if you crank it to 25, like your portables do. You don't want to do that, right? So ultimately, you want to be at your 50 PSI pre-regulator. So if you have this adapter on all of your CPAP, you know as well as I do, we're not going to take the time to screw this thing off to put it on something, and naturally we're just going to plug it into the wall of the ambulance or this adapter on our portable and give the patient the proper thing they're supposed to get. So that's the idea behind that. Secondarily, once you get that flow going, you're going to put that on the patient's face. You're going to allow, and like this picture suggests here, you're going to allow her to hold it so that she can become comfortable with it, and not strap it to her head until she's ready, right? In a lot of cases, guys, the patient's anxious because they've been working to breathe for 5 minutes or whatever it took us to get there, maybe longer than that in a lot of cases. They typically don't call for right away like they should. And so you're going to let her understand or feel comfortable with that before you strap that to her head. And what's interesting about your unit versus most other units on the market is, and I'll go into that probably a slide or two from here, more in depth, but why they're uncomfortable is because they're afraid they can overbreathe what that device can do. So you put them on an non-rebreather mask, and you're talking 15 liters a minute or so, and somebody can overbreathe that. They can breathe faster and more volume than that if they're really working to breathe. So I'm sure you guys have seen it. I know I have. Put an non-rebreather on someone, and in a few minutes they're ripping it off. Well, they're ripping it off because they're overbreathing the device and they're not getting what they need. And this device, because it delivers 140 liters a minute, test question, it's not likely that someone can or even possibly overbreathe that. So let them become comfortable, strap it to her head. And then, as you can see here, this is pointed forward, and the vent, the vents for the exhalation valve are both on the side, so it's not going in her face. So what I want you to see, yeah, go ahead.
Yeah, no, I think you bring up a good point. I just want to, jump on top of that. That is one reason why this CPAP, I mean, we sell other CPAPs, right? And we have other CPAPs out there that are being used every day. But that is why, I mean, really, this one is the best. And that's why you have some apprehension from folks at different times to put on a CPAP, is because they've been given a CPAP that's running off a normal oxygen supply line, and they were over breathing it. I mean, you take a normal size adult male,
Yep.
they will over breathe a CPAP that is using a O2 supply line every time.
Yes.
There isn't nobody over breathing the Pulmodyne CPAP. It's just not happening. And I guess I would articulate it this way: is I would challenge somebody to get on a treadmill and really get worked up, right, till you're out of breath,
Yeah.
and then put the vent tubing in your mouth, and then put an O2 cannula in your mouth, or supply tubing, and see which one you pass out with first, right?
Right.
Because, I mean, that's really what's happening to these folks, and that's why they're apprehensive. That's why, I mean, most people, if they would have started with a CPAP that they weren't over breathing,
Yes.
and they could understand it,
Mhm.
they wouldn't have as much apprehension or anxiety.
You're spot on. That's right. So gang, then if you look at this next picture, you'll see that this is, here's a couple things I really want you to see, right? So this is going to tell you a few things on troubleshooting your system if there's an issue. So first and foremost, this is that anti-asphyxia valve I was talking about. And what happens is there's holes right here. And if there's no flow coming in, air and oxygen not flowing in, or not enough of it, that anti-asphyxia valve is going to drop down, and ambient air is going to come in so they can breathe and they don't asphyxiate. So, obviously that's key to look at. And in this case, that could be a sign if someone was if they somehow were over breathing this or any other device, if the anti-asphyxia valve drops, even flutters down during their exhale or their inhalation, they're probably over breathing that device because the device isn't providing the flow that they need. And in this picture, you can see this. You can see that the anti-asphyxia valve is up and that the flow is coming in, and they're actually exhaling. You can see that this pressure, the exhaled air is creating this to open up and allow that to go out. And what's funny, that's what's creating that PEEP, right? The spring tension that you have down here, in this case it's 5, is what they're breathing against, right? And that's up. And that's really what you want to do. What I love about this slide is I like to point out this. This CPAP is made in Indianapolis. And most of the people that work at this organization are former paramedics or current licensed paramedics, and at least in the leadership roles. And what's neat about it is this: they take feedback from EMS providers in the field and make additions or changes to this device. And there's a bunch of them right here. So this adapter was one that a medic said, I wish we could just plug right in. They made the adapter. This integrated neb was another one. They said, I don't want to put pieces together. Can't you just put this in line? They did it. This piece up here, they found was not as durable as it probably could be in EMS. So you'll see that ones you buy today actually have a white piece of plastic here instead of clear, because it's more durable now. You'll see over here this, as I said earlier, you want to see this raising up a little bit so that you know that it's that they're exhaling and that they're not being given too much PEEP. And one of the medics that gave some feedback said, listen, 3 in the morning, if you want me to see that thing's rising up, this used to be white. They realized that we needed to make a color change to make a differentiator here. And so within just a couple of weeks, all of a sudden you saw these things coming out with orange. So real big benefit to being made domestically, and quite honestly, right across the border from where we are, kind of helpful. Pulmodyne's super excited about this. I'm not so sure the bull in the china shop is, but they are. So they get excited about the fact that their port on the side of this nebulizer has a cut in it. And some of you guys might be excited about this. If you need to add more medicine, while that's going, you can pop the end of it right in there and do continuous nebulization. Me, again, bull in the china shop, I'm probably gonna pull it off, keep the line, squirt in the top and stuff it back in. But either one works. So let's talk about a couple of different considerations. One, if for some crazy reason you notice that that it sounds like there's not a lot of flow moving like it should, like you're not used to hearing, if you notice that anti-asphyxia valve is opening when they take breaths in, I know you guys use disposable bottom sheets, but you're using the linen from the hospital for the upper stuff. So if this, this thing's drawn in 125 liters, right? 15 off the tank, 125 through there, making 140. 125 liters is a lot of flow, right? And if you put this up against the sheet, it's going to suck that sheet right to it. So again, first thing I would do if I saw that anti-asphyxia valve moving on this unit, I'm looking at the sheet. Did this get moved around? Did the patient move their leg around? Is something causing this to go up against the sheet or something else? So that's number one. Number two, the blend of the air and the oxygen in this system gives around 30% FiO2, which stands for fraction of inspired oxygen. And what that does, or what that tells you, or some people will tell you, is that may not be enough for some people. But we all know that in most cases, your respiratory distress problems are because of a surface area issue. The not enough of the alveoli are recruited and being used, and that's what's causing their problem. Not necessarily that their oxygen levels aren't sufficient at 30%. But let's just say that you believe that this is a condition, and there are some conditions out there. You believe this is one where you need more oxygen. Obviously, first step is to turn on your cannula and your Untitled CO2, and you can move that up to upwards of 5 liters a minute. Again, something I didn't know before I came here. It's not like a normal nasal cannula where you go up to 6. This only allows you to go up to 5. So that's the first step. And by doing that, you can get this FiO2 up to somewhere in the 40, 41, 42% range. If you don't believe that's enough, you can pop open one of these caps on the front of the mask and put some oxygen supply tubing on. And then there's honestly there's an equation that is 4 times whatever liter flow you put it at plus 21% ambient air. And if obviously it's got to be higher than 30%, if you don't give enough to be higher than 30%, then that's it's going to use the 30% from the device. So if you put that at a higher flow, you could bring that flow up, or that FiO2 up significantly. They also have this other device called a trio that you can put on, but basically this is going to be your first line of defense to increase your FiO2 if you feel like you need to. So like I said earlier, if you happen to see that anti-asphyxia valve drop, gang in the room there, what are your concerns? Two things are happening. One is what? What do you got? Well, one.
Sorry, we got guys talking. We forgot we were muted.
No worries. What you got?
They're either overbreathing the mask or the valve is plugged.
They're either overbreathing the mask or the valve is plugged.
You got it, right. So they're either overbreathing or that valve is plugged. And what I mean by that is this. Here's a pulmonary function test, a depiction of a pulmonary function test. So if someone's really gasping, and this is another thing I learned from that foam frat people. So this is a typical pulmonary function test. What most of us are taught is that a high flow respiratory device in EMS is a non-rebreather. But like Don just talked about a minute ago, the average person who's really working to breathe, I shouldn't say average, there are a number of people out there that are really working to breathe that can overbreathe that device. And in the respiratory world, the term high flow respiratory device is actually a fluid term, right? It means it's a respiratory device in which the patient is not able to overbreathe at their current condition. So quite honestly, a simple mask or any of those things could be a high flow device. Hell, a nasal cannula, a high flow cannula could be a high flow respiratory device. But it really depends on what the patient is needing at that point in time. And here's an example of a high flow or of a pulmonary function test where someone gasping could breathe 30, 35 liters a minute, in their gasp. So like Don pointed out earlier, a device that works off of a 15 liter a minute or a 20 liter a minute system without a venturi to bring in more ambient air, can be over breathed pretty easily, right? And so this is a great depiction of that. So I'm hoping that it'll help, change some of the mindset of, you got to have a device that's going to do it. And in this case, your CPAP will do that. Not everybody else will. Now, obviously, in today's world, they want med controls are kind of pushing us against CPAP, at least in the current day because of COVID. But with this device, there's really no reason not to, right? And the reason they're telling you not to is because they're looking at most devices that don't have this ability. This device has the ability to put a filter right underneath that exhalation valve. So you've got the filtration coming in to the system as well as the breath coming out. And just within a matter of a couple of weeks, you guys are going to see this coming in on every device just as normal, but we can put them in line now. So if you have any CPAP in your system today that does not have this, yell at Josh and we'll get you the number you need for your CPAP to put these on there. The other thing I want to point out here, guys, is this. Think about pollen season, right? So during pollen season, you've got, there's pollen everywhere, right? So if you put this on a CPAP device in general on somebody without filtration on the inlet, you're potentially pushing pollen down into these lungs, right? And if you've got a person who is allergic to pollen, the next thing they're going to be needing some Benadryl, right? So again, this device is great, having filtration on both sides. So let's go. So a couple more questions here. When a patient gasps for a deep breath, they can move as much as 5 to 10 liters a minute, 10 to 15 liters a minute, 20 to 25 liters a minute, or 30 to 35 liters a minute. What are your thoughts? All right. Beautiful. 30 to 35 liters a minute. So you got to have a high flow respiratory device to manage that, right? How about, a lot goes in, how about the O2Max CPAP system, which is the one you guys use, can deliver approximately, and this is going to ask you to type in a number, X number of liters per minute to the patient, approximately. Love it. 140 liters a minute. So 125 is what that the filtration area draws in for ambient air. It draws 15 liters a minute off the tank, 125 through the filtration system, giving 140 liters a minute to the patient, approximately. Obviously, there's friction loss in there, but basically 140 liters a minute. Good, nice work. So lastly, I want to make sure you guys look at this. I often hear this. I used to hear this as a EMS administrator too. I'd have crews tell me, listen, I didn't put someone on CPAP because I was 3 minutes, 5 minutes, 10 minutes from the hospital. I had other things I was doing, right? They always have this reason why they didn't do it. And that's what we like to do, right? People like to justify why they do or don't do something. And it's normal, right? But what I want you to look at is this. And I used to do the same thing with pain management when I worked in the field. And I use this justification of why I did it. So if you think about it, you're at your patient's bedside, right? You get to the scene, you start looking at the patient, you're starting to do your assessment, you're trying to figure out the scenario, you're bringing, getting their meds, writing those things down, everything we do on a regular basis. That's likely going to take you, even though we like to think we're off the scene a lot faster than this, it's likely going to take you 5 to 10 minutes, even on a really sick person. It's going to take you about 5 minutes to load the person up and get going down the road. Let's just say you have a 5 to 10 minute trip time, right? How long it's going to take us to get to the ER. And then here's the big differentiator that most of us don't think about. The time we call out on the radio at the hospital or through the MDT at the hospital, that's not when the patient's actually getting treatment from that hospital, right? Any hospital. It's just not normal. It's a very abnormal to get treatment right away, even in a trauma room. So you're looking at 10, 15, 20 more minutes till somebody's in there talking to that person and treatments are actually happening and they've done their own assessment and they're starting to do things. So realistically, even at a 5 minute trip time, that person, if you did CPAP at the bedside, could be it could be like 20 to 40 minutes that person's been on CPAP. And like we talked about earlier, even in the sickest of patients, or even if a person ends up on a vent at some point, if you've had them on that pressure for longer periods of time, they're going to do better. They're going to have less time on the vent in most cases, and they're likely going to have a shorter stay. So it's super important to get that CPAP on early and often. Another consideration that I didn't think about until I talked to my friend Richard at Pulmodyne. He talked about a thing he's finding out across the country. They're starting to use these things on firefighter rehab. So think about this in not that it happens terribly often, guys, but if you grabbed an oxygen non-rebreather mask and you sucked on that while they changed out your bottle, evaluated you for CO levels and did some rehab, that helps. But think about if you put the CPAP on during that time, just held it to your face, took some deep breaths, and breathed, exhaled against that pressure, you're going to recruit more alveoli along that process, right? And you're going to be able to exchange gas better, and more than likely be in a condition to get back into that fire and do more sooner. Makes a lot of sense, right? So in the end, guys, I want to thank you for having us. This is, I appreciate you so much. I know Boundary appreciates you so much.